my charge was actually kind of provide an overview of some of the activities currently being done on the companion animal side. And many of you probably think, well, is there anything being done on the companion animal side? And I can say that yes, there are. And actually, I think it's been quite exciting. And actually, it's been a lot of fun to do this. And I am just one of the many members of our committee that is presenting this. Actually, Dr. Watts, I think, is in the room, and he's also on our committee as well. And so I'll just be presenting some of that information. But to give you just a quick overview or an outline of where I want to take you, one is just an overview of the issues of antimicrobial resistance in companion animals, a brief discussion about stewardship program building on basically the two previous talks, focusing a little bit on the AVMA task force activities and some of the things that we've been doing, and then lastly, what are some of the educational outreach activities that we've been doing. So when you think about the issues that we deal with in veterinary medicine, they are somewhat similar, but somewhat different than actually what is being experienced on the human side. For us, and especially if you look at our companion animal issues, methicillin-resistant staph is the biggest issue. And it's actually been quite disturbing as a hospital epidemiologist looking at the patterns and the difficulties that many of our clinicians are wrestling with. They are at the point where we don't have anything that we can use, especially when we deal with staph pseudointermediates, staph schleiferi, and actually the other ones that we are seeing some spillover in from the human side is our Staph aureus infections, Methicillin Staph aureus. But at the same time, we're also seeing multi-drug resistant E. coli's, we're seeing multi-drug resistant Klebsiellas, Acinetobacters, all sorts of things that do spill over into our companion animals. Now, a couple things that I want to just put into context is when you look at companion animals in humans, pets, especially cats and dogs, are potential sources of spread of antimicrobial resistance. Now, the direction is bidirectional, of course, are common because, or is an issue because of the common use of antimicrobials and their close contact with humans. So that's easily to be grasped. At the same time, when you look at, measuring, and we don't really have any good measures of antimicrobial use in the United States, so I take here some out of the EU in particular, and they've noted that in 2002, and I believe that data is reflected in more recent data as well, that companion animals and non-food animals accounted for about 37% of the pharmaceutical sales in the EU. Oftentimes, especially in companion animals, there is not a lot of culture being done, and so we don't know if that susceptibility profile is being done or if the appropriate antibiotic is being done as well. Also, pets often receive what we consider medically important antimicrobials such as cephalosporins as well as fluoroquinolones. Now, if you look at, this is just actually from our dermatology service, I asked the question as to what things are we culturing from, I like to laugh and give our derm folks a hard time. They're the dirtiest place in the hospital. So you can see that we've got MRSP, that's methicillin-resistant staph pseudointermediates. You can see that it's been increasing the number of cases that we do see, and actually it's been a fairly constant number of cultures that is. So that actually reflects a change probably in what we're seeing in our hospital population. This is not only evidenced in our hospital, but it's been evidenced in other teaching hospitals across the country as well. This has actually become more of a problem. I also just highlight MRSS, our Schleiferi infections, as well as MRSA. We don't see that many in our teaching hospital. The other thing that is, if you look at the community issues, and so one of the studies that we did is just looking at dog parks. And we actually went to dog parks and asked people would they be willing to provide poop samples, and they graciously said yes. And so they wondered if we'd pick them up for them, but we asked them to do that, and with that, we actually sampled for E. coli, and specifically we were looking for resistance. And it was interesting to note that almost a quarter of them demonstrated resistance to an MC. So basically the penicillins and cephalosporins are going to be affected here, just in these fecal E. coli's that we're doing. We also noted that about 2% of these had extended spectrum beta-lactamase producers. So again, highlighting even in a community setting, a healthy dog walking around in a setting, commingling actually with other dogs, that they're drug resistance. And many of these actually isolates were multi-drug resistance as well. Also, as you can assume, that if you go into a hospital, and if you go into our teaching hospital, that there should be a difference in what we see between those patients that are outpatients or community patients coming in for vaccines and various things versus those that actually are in our ICUs. So if you look at just in this particular slide, the number or percent of multi-drug resistance, MDRs, in the ICU patients was about 37% versus 4% in our community practice. So basically, if you're using antibiotics, you're providing that selective pressure, of course you're going to see more drug resistance. So with that, infection control practices need to be greatly enhanced, especially for those, in a sense, immunocompromised patients that we're caring for. So I think it gets a little bit to the why of why we're here, and really talking about the selective pressures, and I think it's been really emphasized well, is that regardless of use, appropriate or inappropriate, that selective pressure of antimicrobial underscores the importance of prudent use to slow the development of resistance. I highlight here, actually, it's Dr. Fishman, actually from Penn, I believe, that coined that. Also, when we think about inappropriately prescribed antibiotics, I stole this actually from Stanford, actually a Coursera course on antimicrobial stewardship, that the absence of bacterial infection or indication for prophylaxis. Why are they inappropriately prescribed? But basically, we're doing it where there's no bacterial infection. Also, are we violating one of the Ds, the following Ds? And are we providing the wrong dose, the right drug, the best route of delivery, the attention to de-escalation, I'll talk a little more about that, and also the appropriate duration of therapy or administration. And actually, it's interesting to see the definition of stewardship that we've thrown up here. This is the one that I'll put up here. The primary purpose of stewardship is to optimize clinical outcome while minimizing unintended consequences of antimicrobial use, including toxicity, which I'm glad to see was highlighted already today, that the selection of pathogenic organisms and the emergence of resistance. So in the human hospitals, what are some of the commonly used techniques that they've been doing in stewardship? So I just actually provided here a list of some of the ways that they've been trying to do this, and actually with some success. One is clinician education, formulary optimization, antibiotic use restrictions, prospective audit, intervention, and feedback. As we heard, that if you don't do that, it's time to go back up. I actually thought that was a fascinating study. Optimization of dose administration, streamlining or de-escalation and elimination of redundant therapy, early switch from IV to oral antibiotics, appropriate duration of antimicrobial therapy, and then also clinical guidelines with site-specific treatment pathways. So that's what has been encouraged or developed on the human side. And if you look, some of the general recommendations that come out is treat infection, not colonization. Ideally, culture before antibiotic treatment, but provide antibiotics as soon as possible, especially when they're needed. And then the other thing that I think was very important, a good reminder for me and our clinical staff, is evaluate the patient daily, especially within 48, 72 hours, and take what they call routine antibiotic timeouts to reevaluate your therapy. And that timeout, really is a relationship between the host, the bug, and the drug. And so part of that is that reevaluating clinical therapy. I know that in our hospital, an animal comes in the ICU, gets put on something. During the course of the stay, say, well, we're going to add something else. But they never go back and evaluate, do they need to be on that original one they put on? They just keep on adding antibiotics in many respects. So part of that is taking this time out to do that. The other is just the clinical response. How is the animal responding? Also looking at that microbiological data. What is that telling us? What is the organism? What does the local antibiogram say into what should be the appropriate antibiotic that we use? And also, what is the susceptibility of that isolate as well? So with that, I'm going to just take a turn now and say, okay, a committee was formed about a year ago to actually try to look at companion animals and companion animal stewardship. And so with that, there were several things that the committee thought we need to do. One is to understand practitioner prescribing behaviors. Why do we do what we do? What are the pressures that influence what we do? Understanding laboratory practices as well. How do we also support regional and laboratory antibiograms, especially when we have limited culture data compared to actually on the human side? How can we encourage the development of guidelines, practice guidelines? And then also, how do we promote some educational programs? The specific one that I'll focus on is kind of a do's and don'ts recommendations that our committee came up with as well. The first actually is a survey of practitioner prescribing practices. And actually, I'm going to present some data that actually we did in Minnesota. And clearly, we just need to understand what the knowledge, attitudes, and beliefs of practitioners were. So we did a survey back in 2011, and basically 85% of folks at that time said, we don't really believe that antibiotic resistance is a problem in their daily clinical practice. I would venture to guess that if I did that now, I think it would be different. I was surprised to see that only 15%, yeah, this is a problem. But I would think that that actually has probably changed. We also asked them, what influences your choosing an antibiotic? And the most influential reasons for choosing a specific antibiotic were owners' finances, antibiotic resistance concerns, potential side effects, and then also client expectations. The other thing is that we know that about 30% of practitioners reported routinely using antimicrobials for clean surgical procedures. And so when we hear that about 50% of the prescriptions on the human side are probably not necessary, I would also venture to guess that probably on the companion animal side that is probably true as well. We've not done that assessment, but I would venture to guess that that is probably true. The other thing that we have actually designed our survey questions, and so those updated survey questions will be going out to a larger, broader group of practitioners here shortly as well. The other issue is the issue of the laboratory, understanding the laboratory. And does the laboratory that we submit to, as veterinarians submit to, do they follow quality assurance standards? And are they following the Clinical and Laboratory Standards Institute? So we recently just have done a survey of that. We just got those results back actually this week. And basically to find out how can we provide some guidance? How can we best report culture and sensitivity results back to practitioners to actually more appropriately guide them in their clinical decision making? And that actually gets into how do we develop regional antibiograms. Now, of course, you're not going to be able to read any of this, and I apologize, but I just want to put this up that this is actually one of the laboratories we actually send our isolates to, and they provide a regional antibiogram. Now, this doesn't make a lot of sense sometimes, especially if you look at who feeds into this regional antibiogram. You know, there could be quite a bit of variability. So we've actually tried to drill it down a little bit more to fit our hospital for very specific conditions. So for example, on this page, I don't know if you can see it or not, but this is basically staph intermedius, pseudointermedius infections from the ear and culture results and that we've put together. And this is actually, again, a pocket size type of product that we're putting in our clinicians to actually help guide them in kind of empiric drug use. The other thing that actually I think has been quite exciting has been an attempt to actually provide some guidance to clinicians. So there's actually two practice guidelines that have come out, one focusing on superficial bacterial folliculitis and the other one focusing on urinary tract disease. And so basically it is the mental algorithm to help clinicians actually kind of think about when do I need to use an antibiotic, when do I not need to use an antibiotic, how do I actually approach these. And actually on the human side, they've done a great job of looking at otitis media and bronchitis and providing that guidelines. On the veterinary side, we've been a little bit more reluctant to actually take that and examine that. And as you can imagine, medicine is an art, and so we can't just script that this is the way it's going to be done all the time. But these are actually nice guidelines that actually provide clinicians, and actually it's a great teaching tool as well as to help our students think about how do they approach these situations or problems. So I highlight these two documents as a positive move forward in dealing with that. On the educational side, there are a number of programs out there. Many of you are probably well aware of the CDC initiative of the Get Smart program. Actually, I think the Antibiotic Awareness Week is coming up November 20th, if I recall. And also there are a number of state-sponsored programs. Many of these are not dealing with veterinary issues at all. There are also some web-based training modules actually that are focused on veterinary that I'll highlight here, and also some client-focused programs as well. So for those who are not familiar with the Get Smart program, but basically it's got a nice information for not only the public and getting public aware of this, Some of the success in antibiotic decreasing is not only engaging the clinician, but engaging the community in that process. And once they understand this, then they actually will think twice about demanding or asking that they get something when they go for their clinic visits, as well as information here that is provided for the prescriber as well. So this is actually a nice resource, a nice tool. I provide here, this is actually our Stop Antibiotic Misuse in Minnesota program, and they have a number of good posters. I've actually been around the world and actually seen, I don't know if you've seen Cover Your Cough, but I was in Rome once and I saw Cover Your Cough, so I was glad to see that Minnesota was moving around the globe. But highlighting the fact that there's a number of educational efforts that are out there. Is there an opportunity from the veterinary side to actually become part of these programs is one of the things that we've been asking as a committee as well. Some of you may be familiar with a program actually we did in partnership with Michigan State University, which is a learning module for veterinary students. With that, we've actually developed some site-specific or clinical modules for companion animals. So actually that's one of the areas that we've actually worked on. So I highlight here one that we did on canine pyoderma. We also did one on feline urinary tract disease as well to highlight just some of these educational clinical modules. So one of the other issues that the task force has come up is what would be some do's and don'ts that we can encourage practitioners to think about? Something they can actually talk to their clients about too, as to why I'm not going to prescribe an antibiotic, or this is when I really do want to prescribe an antibiotic. And so we developed kind of, in a sense, a do and don't list, and actually we're just reviewing the final drafts of this, but these are just some of the general ideas as well as some actually specific ideas that we've put together. And we think about just antimicrobial therapy, general considerations, consider and rule out non-bacterial causes. Consider other therapeutic options, utilize culture and sensitivity results, refer to published treatment guidelines, monitor treatment response and client compliance, take a time out before adding, switching, or changing antibiotic treatments. And then we've actually drilled down to very specific areas. So for example, on gastrointestinal disease, avoid antimicrobials basically in healthy patients with diarrhea. Provide supportive therapy, make a diagnosis before prescribing antimicrobials, and then fecal smears are really not reliable for diagnosing enteropathogenic infections. On the respiratory disease issues, avoid antimicrobials for acute, uncomplicated upper respiratory tract infections or disease. Perform additional diagnostics for complicated disease or chronic respiratory disease. For the urinary tract disease issues, avoid diagnosis based on free catch urine samples. Do not routinely prescribe antimicrobials for a cat less than 10 years of age with lower urinary tract signs, and confirm infections with quantitative cultures. For dental disease, avoid antimicrobial use for routine dental procedures. Avoid antimicrobials with activity against known, or choose antimicrobials with activity against known oral pathogens, and antimicrobials are not a substitute for appropriate dental management. On the derm side, perform cytology of lesions in all cases of suspect pyoderma. Perform microbial culture and sensitivity, as well as additional diagnostic to investigate recurrent or refractory pyoderma. Use topical shampoos and antimicrobials when possible. Perioperatively, adhere to best practices for infection control in the operating room. Avoid prophylactic antimicrobials for routine surgeries. And if antimicrobials are used, then administer those IV 30 to 60 days before surgery cut, and do not administer them beyond the perioperative procedures. I recently just did this talk in New York, and one of the things that actually raised probably most concern was the issue when I brought up vector-borne disease and vector-borne disease recommendations. But basically, avoid antimicrobial therapy in animals that are seropositive for vector-borne pathogens. Seropositive does not imply active infection. Recommend preventative treatments for ectoparasite control to prevent infection or the spread of vector-borne pathogens. Some other things, and so that I think have been exciting. One is an app actually developed by the Canadian Veterinary Medical Association called SmartVet, and actually it is an app that actually walks a clinician through a urinary tract infections, providing guidance. So increasingly with most of our information now being on the phone, I think that this is a nice tool. The other thing that we've been exploring for our hospital is a clinic antibiogram app. Can they have it on their phone and more readily available to help with their empiric drug choices? Also for our hospital, we do have a stewardship team, and that includes myself, a clinical pharmacologist, a microbiologist, and our infection control practitioner, and then clinicians both on our small and large animal side. And so we're in our infancy in many respects, but actually this has been good, and actually it's been exciting to watch the enthusiasm to actually look at this issue. So that's a very quick whirlwind of basically the AVMA activities that we've been doing, things that we've been doing in our own hospital. And just to reemphasize actually our two previous speakers is that, really antimicrobial resistance is really going to be a grand challenge. And as clinicians, we need to be aware and encourage good antimicrobial stewardship practices.